Okay, everyone, I think we're going to get started because we have a time schedule and you all have other things to do tonight, probably. If not, maybe sleep. So I'm Don Barber and I'm the Executive Director for the Greater Tompkins County Municipal Health Insurance Consortium. And on behalf of the Board of Directors, I welcome you to tonight's event. Yeah, how is the audio? Is it all right? Good. So the vision for tonight's retreat is to create a common knowledge base for those associated with the consortium. And that includes the board of directors, the operating committees, and the leaders of labor and local government. Our goal is to explain the basic concepts of health insurance, or in other words, Health Insurance 101, how insurance and specifically risk pools work, the basics of how our health care system works, an interaction between insurance and healthcare providers, then further an appreciation for the change in healthcare and regulations that impact insurance companies, and finally frame the challenges facing the consortium. So here are the specific topics that we'll be introducing. I must say that this retreat is not the opportunity for the presenters to show their mastery of the subject matter, but rather it's an opportunity for you to come away with a stronger base of understanding about the business we find ourselves managing. So ask questions as we go along. Remember, this is Health Insurance 101, so there are no dumb questions because this is the first time through this material. I have an easel behind me here to capture any questions that may take too long and are not part of our presentation, but we will provide answers to you if we have your email address, and we'll follow up for sure. So taking those specific questions from the previous slide in order, here's a rough timeline for this evening. And you can see on there that we will break at 6 o'clock. And that's for a break for a stretch and a chance to grab some healthy food that's over in the corner back here. But we need to come back in 10 minutes, so the break, not to break the train of thought, and to keep the information sharing going on time. You also will have received a raffle ticket when you came in, and there are raffle prizes back here, so you can inspect those as you go to the bathroom. You have to be present to win, and you'll notice that it's at the end of the event. No escape now. Yeah, exactly. So there are bathrooms that are located to my right, your left, over here in the corner. There are fire exits at both the front and back of the building, in case something happens that it gets really exciting in here. So I want to introduce tonight's presenters. Of course, I'm Don Barber. I'm the Executive Director for the Consortium. Also, we have Steve Losey to my right and your left, a managing partner with Losey & Cahill, and our main consultant that we've had since the beginning of the consortium. Have Beth Miller immediately to my left, who's the managing account manager for Excelis, and to her left is Asia Masucci, who's the account manager for ProAct. So at this time, I'd like to do is have each of you go around and state your name and affiliation with the consortium. And I have to say that for those that are not standing near a microphone, or even if you are, speak loud. The acoustics in here are not the greatest, and we'd love to get a feeling so each one of us knows who's in the room and your affiliation. So we'll start with Deb.
Debbie Prado, Commissioner of Personnel, Tompkins County.
Hello, Brooke Jobin, Benefits Manager, Tompkins County.
Sharon Bowman from the town of Lansing.
Kathy Miller, Supervisor, Town of Lansing.
I'm Glenn Morey, Town Supervisor of Groton, and I'm also sitting on the Finance Committee.
Scott Weatherby, I work at TC3, and I'm the chair of the Joint Committee on Plan, Structure, and Design.
Melissa Schmidt, I work at TC3. I'm here representing our faculty association.
Olivia Hersey, I also work at TC3 and I represent our Professional Administrators Association.
I'm Rorden Hart. I'm from the Village of Trumansburg Board of Trustees, and I'm also the Vice Chair for the consortium.
Marianne Sumner, Supervisor, Town of Dryden.
Rich Goldman, Trustee, Town of Ulysses.
Jennifer Case, Bookkeeper, Town of Dryden.
Jim Bauer, Bolton Point, Town of Ithaca, UAW 2300, Bargaining Unit Representative.
Mike Solvig with the Town of Ithaca. Judy Drake with the Town of Ithaca, Human Resources. I'm also chair of the consortium.
Debbie Kelly from the Town of Ithaca, and I also do part-time at Town of Enfield. This is Stanley Shire of Town of Ithaca.
Bill, can we get you back in the corner?
Bill Goodman, Deputy Town Supervisor, Town of Ithaca.
Okay, Betty, we'll start with you.
I'm Betty Falco with the Human Services Coalition.
Leslie Connors, Town of Yankee.
Rebecca Leonard, Town of Yankee.
Jim Hallhead, Town of Yankee.
Dan Ryder, Supervisor, Town of Enfield.
Rick Snyder, Finance Director, Conference County, and you're Treasurer for the consortium.
Beth McGee, Council President, Town of Enfield. Emily Miller, Tiger, and
Eric Rothmeyer, full water system.
Ted Shealy, I work at the County Health Department. I'm a member of the Owning Your Own Health Committee, the Wellness Committee for the consortium.
I'm Marissa Carlisle, the Town of North Town of Ulysses. I'm Nancy Taylor, on the Ulysses Town Board. I'm Kate Sullivan, on the second ward alderman for Portland. Shelley Michelle, now City of Ithaca.
All right, we got a great group here. Thank you all for coming and making tonight a priority when there were so many other nice things to do, especially with a bright sunny day. But I also like to acknowledge those who made this event possible. In addition to our presenters, we have Michelle Potteroff, who's the administrative clerk for the consortium, and she just dove into her office there, but coming back out. We have taping this event tonight are Michael Cederstrom and Jim Blizzard. They are, so this will be posted on the website in case there's something in here that you want to share with your board or your group that'll be available. And also we have Kathy Covert, who works with Michelle, has been really stalwart in bringing forward a lot of this event tonight. We have Excelis and Proact. I want to thank them for the scrumptious food that's on and healthy food that's on the table. And then I want to really acknowledge Steve Losi, who's gone above and beyond, again, gathering input for the PowerPoint that we have today, assembling the thoughts from 4 different authors. So thank you so much, Steve, for that. And of course, he's very humble. So moving right along, we'll start right off with healthcare basics. And Beth Miller.
Thank you, John. Okay, let's jump right into the presentation. And we're going to start out with just the basics. What is healthcare? And believe it or not, this is just a simple definition from Wikipedia. Healthcare is a diagnosis, treatment, and prevention of disease, illness, injury, and other physical and mental impairments in human beings. So there you have it. It's a definition. It's the beginning of really where healthcare is at. You can go. Healthcare is a business. Make no mistake. You are a consumer in the equation of healthcare. You purchase goods and services, whether they're tangible or intangible, whether you get a piece of durable medical equipment, a wheelchair, a walker, or crutches, or you have an X-ray read by a radiologist. These are services, and you are part of the mix. You are marketed to as a consumer, and saying that healthcare is a business, it's actually part of CPI. CPI is price index, consumer price index, and that measures the time or the cost of goods over time. So when you take a look at healthcare and the healthcare spend, it is approximately 17% of the gross national product. So it's part of that $16.8 trillion. So as a consumer of healthcare, we have choices. And that is things that you think about when you're accessing care. Where can I get care? What's the right place of service that I should be seeking care? Should I go to the hospital? Should I go to the doctor's office? Or do I just need an urgent care center for a quick X-ray on a sprained ankle? Do I really need this service? Should I wrap it? Should I take an aspirin? Call the doctor in the morning? Can I hold off? And then a big question that we probably ask ourselves just before we go to hand our insurance card over at the check-in desk, how much is this going to cost me? What's the cost of the service that I am initiating? So some common places of treatment, they all look familiar. It's a hospital, inpatient, outpatient, a skilled nursing facility, urgent care. But believe it or not, these types of common places have been changing throughout healthcare. When you're going for inpatient services, a lot of inpatient surgeries that used to take place 5 years ago are now being done in the outpatient, or they're being done in a doctor's office. You don't have to go to the emergency room just to get stitches. That can be handled at an urgent care. So as we look at healthcare as a consumer, things are changing before our eyes. Common services, types of services that we seek, we go to our primary care. We have a sore throat, we go in, call the doctor, and we're lucky enough to be seen usually within the same day that you call your provider. We have after-hour cares because heaven knows it's always getting sick just before the holiday at Thanksgiving or on Saturday. So office hours have been extended, so you're able to utilize your primary care, which, when you think about it, knowing the structure of your own plan, where you access care, determines your out-of-pocket cost. So going to an office visit typically is the lowest cost out of your pocket for your personal checkbook, but it also is the lowest cost for a claim when it comes into the claim processing and through the consortium. Now I'm going to turn it over to Ashley.
And just like there's many different types of medical places to receive services, there's also many different types of prescription drug benefits that are covered by your benefits. You've got your generic medications, which are the least expensive medication. On average, it costs your prescription plan $17.92 per each generic medication. 78% of all of the prescription drugs filled by the plan were generic medications in 2013. There's also brand medications, which are most of the time much more expensive than generic medications, on average costing over $245 per medication. There's also specialty medication, and specialty medication is a very hot topic in the prescription drug industry right now. On average, those costs are exceeding $2,500 per specialty medication in the industry. For the consortium in 2013, it was $2,205. And these specialty medications are the medications used today to treat chronic or ongoing, more serious conditions that maybe in the past a person would receive treatment at a hospital or doctor's office for through methods such as Infusicare or IV treatment. And in the future, in the prescription drug industry, we only expect the cost of generic, brand, and specialty to rise. And that's because more people are able to treat their conditions through prescription drugs instead of seeking care on the medical side.
So when you talk about your cost of care, you're thinking, oh, deductibles, coinsurance, or a copay, where do I come into play? However, another thing to consider is the provider an in-network provider or participating provider or non-participating provider? With Blue Cross Blue Shield, you actually have access to national networks. So if you're traveling and you're in Florida and you have an emergency, or you want to go to a Mayo Clinic for a specialty surgery, you are able to do that and still receive treatment just like you were here in Tompkins County. Non-covered services, non-covered providers, you would be paying the balance of that. However, luckily, within the consortium, you have over 97% of the members of the consortium that utilize participating providers, which then again leads to enormous savings when it comes to paying the bills for your claims. The other thing that you talk about when you look at cost, remember we said that healthcare spend is 17% of the gross national product. That's actually about, for an average family of 4, 25% of their income. So that is scary. And at this rate of inflation, you're looking at that percent to be pushed up to 50% over the next 20 years. So it is important that we're here today going through and taking a look and getting educated at what's going on with health care. So when we talk about health care, it's a three-legged stool. And as Don pointed out to me, you, the patient, and the insurance plan are the outside holders of the stool. There's also the medical provider. It's a collaborative effort that you need to work together in determining the right price, the right service, and that you're asking the right questions. Health insurance is a complex industry. It's not just one size fits all.
All right, that's our first part. And are there any questions? Please, Jim.
Beth had mentioned that if you were across the country, that Blue Cross Blue Shield provides a national network. So are these in-network providers, or would they be considered out-of-network?
Good question, Jim. If they're participating with the local Blue Cross and Blue Shield, so if you're in Florida or whether you're in Pennsylvania or taking a trip out to California, if the provider, the doctor, or the hospital participates with the local Blue Cross, they are considered in-network for your plan.
Great, thank you.
Yep.
Another question? Ann?
You said just at the end of the presentation that families of 4 are going to have to pay 50% of their income towards health care?
That was, yes, that's some of the information off the internet that I read, and that was an article from 2010, that the cost of care is rising that quickly.
Cost of care is rising, but what I heard you say is families are going to have to pay 50% of their income towards health care, which is different than health care rising, costs rising.
I think what she was referring to is that the cost of care for an individual is going to equal about 50% of their income. Not that they have to pay that out of their pocket.
Sorry.
That's quite different.
Yeah, you have to pay the whole thing. If you have health insurance, you're fortunate enough to have that protection, then the health insurance will pick up a lion's share of that cost. But I think that's what the reference is.
Thanks, Steve.
Any other questions? Please.
On the prescription drug basics, the generic medications, it said that the average cost for a prescription was $17.92. Is that the cost for the consortium or for the individual?
The question proposed was on slide 13, where it says prescription drug basis. It says the average cost of a generic prescription is $17.92. That's based off of 2013 data. And the question was, is that the cost for the member or the consortium? The answer, the cost of the consortium. That's what the consortium is paying on average per each generic drug. So the question proposed is, do we know what the members are being charged? We do, and it's different for every different benefit plan because it would be based off of what the generic drug copay is that the benefit plan the member is enrolled in offers. So it could be $5, $3. It depends on your entity's prescription drug plan structure.
All right.
You're welcome.
I think we're going to move on to Steve Losey and the next section, which is Health Insurance 101.
Yeah, Beth spoke a lot about, the basics of medical care, what medical care is, how we kind of access medical care. We talked a little bit about the three-legged stool. I'm going to give you a little bit of information about one of the most important legs of that stool, which is health insurance. Obviously, as we discussed, medical care is going to cost upwards of 50% of the average person's income going forward for the average person. Health insurance is a real huge part of that, something that we absolutely need to help protect us and to cover some of that cost. In terms of why you need health insurance, a couple bullet points that we have up here: illnesses, disease, and injury.
The reason is so they can tape it.
Oh, I'm sorry. Oh, I don't have an inside voice. That's the only problem. I apologize. I figured I didn't need it for, I didn't want to sound like I was, they'll have to let me know if I sound like I'm yelling at them then. In terms of some of the bullet points for why we need health insurance, I mean, most of these you probably would know on your own. Obviously, illnesses, disease, and injury for human beings is extremely unpredictable events. We certainly fluctuate a lot in cost and services that we need from year to year. The cost of service can be exorbitant. We've had a lot of cases in the last couple of years where individuals have spent more than $1 million in a year on medical care. Prior to the last couple of years, I'd never seen $1 million case before. So costs are definitely rising. Approximately 20% of the population spends about 80% of the premiums or the healthcare dollars. That's important to understand as well. We may spend many, many years in the 80th percentile where we're not spending a lot of the claim dollars. And then all of a sudden we find ourselves or a family member, due to whatever unfortunate circumstance, in that 20% realm, and certainly having health insurance is important to that. Pooling risk protects us all from financial catastrophe, whether that's an individual or an employer. Obviously, we're pooling risk as a consortium amongst the employers and amongst the members, and that's protecting the group. Patient Protection Affordable Care Act requires you to have insurance. So we're not only is it a good idea, it's the law. We have to have insurance as adults these days. And again, one never knows when you're going to be part of that upper 20% of cost. In terms of the definition of health insurance, it's pretty simple. Health insurance is an agreement between a person or the person's employer and a health insurance company where they promise to make certain payments on your behalf, and you pay them premium for that coverage. The amount of premium is going to fluctuate greatly depending on the level of benefits that you have. So obviously, if you have a benefit plan that's only covering 50 or 60% of the average person's cost, their premium is going to be pretty low. If you have coverage that's providing about 90% of the average person's cost of care, that premium is going to be substantially higher. And even though our use of medical services increases with age, our premium typically does not. In New York State, for many years now, we've never, or I shouldn't say never, for the last couple of decades, we haven't had the ability to basically medical underwrite for health insurance. With, like, for instance, life insurance, when you go for a life insurance policy, they'll have you fill out a questionnaire about your basic health. They may actually do a screening, maybe draw some blood, take your blood pressure, may even go a little bit deeper than that if you're an older individual or someone with some health risk. And then they'll assign your premium to you specifically based on your health risk. In New York State, we can't do that relative to health insurance. So everybody pays the same rate for health insurance, whether you're 20 years old, 40 years old, 60 years old, or 80 years old. We all pay the same rate for health insurance. And just to give you an idea of some of the big fluctuation. We put just a quick example from one of our clients of a large loss report in the packet. And you can see that in this particular example, only 14% of this population spent about $3.5 million. And that's substantial. In 1 year, we had an individual who went from spending about $13,000 to over $400,000 in the preceding year. Now, obviously, it gets you to the volatility and unpredictability of medical care costs, tells you why you absolutely need that health insurance protection today. In terms of the consortium, and to give you a better understanding of how health insurance premiums are set for the consortium, this is really just to give you kind of a basic understanding of that if you haven't been involved in the process. In terms of predicting our premium, the first thing we have to do is look at our expense budget. Our premiums are directly related to the expenses that we pay through the consortium. The program is self-insured or self-funded. As a result, we have to look at all of our expenses from paid claims to administrative expenses and overhead expenses, insurance costs, taxes and fees, and come up with an estimate of what our budget's going to be for the year. That tells us how much income we have to generate. Once we have that number, we basically determine our basic income level based on individual. So an individual person covered under the plan, a covered life, what would it cost for us to generate based on the number of covered lives we have, that income level? And then from there, we distribute the cost based on benefit design. So we start with that base premium dollar, and then we look at, okay, do we have individual, do we have family? Family is obviously a component of individual, so it's X number of times the individual rate, and also the benefit, underlying benefit plan. If I have a $100 deductible and someone else has $200, our premiums are going to be different. We have to vary the premium based on those benefit differences. So that's kind of the process that's involved in the rate setting. And just to give you an idea of some of the components and major components of some of our costs, obviously claims is about 94% of our budget, as you saw in the prior example. But you may question why we had insurances on there. Well, even the consortium has to purchase insurance to protect the finances of the group. Whenever we have a catastrophic loss or a number of catastrophic losses, obviously it's going to change our equation, could change our budgeting, our forecasting, our financial results. So we do purchase stop-loss insurance to protect the group. It's required by Article 47. There's basically two types. There's aggregate and specific. Aggregate covers the entire group population of claims. So if our entire group exceeds a certain level, we get reimbursement. Specific covers individual people. Basically like a high deductible health plan. We have a deductible set at a certain level. If someone exceeds that deductible level, the insurance kicks in and pays us back. So it's really just a protection to the group as a whole, and it's an insurance on top of insurance that we purchase to further protect the financial integrity of the program. Does anybody have any questions in terms of kind of the basics of insurance? I mean, we want to make sure that as we're going through this, that if you do have questions that come up, if you let us know, we'll certainly try to address them.
Your stop-loss threshold is $300,000 for the...
Currently, it's $300,000 for individual on specific. That's correct.
And if you lower the threshold to $125,000 or $150,000, what would that do to overall costs?
Premium would rise significantly. And then we'd have to do an analysis between basically risk and reward analysis. If we lower the deductible, how many people are we likely to have exceed that level? How much money would we get back? And then what's the premium increase that we would have to pay out in order to have that lesser deductible level? And then we'd have to balance the two. One of the things that we've done recently is we actually have established a catastrophic claims reserve as part of our overall financial structure so that we could probably raise the deductible a little bit, absorb that inside our catastrophic claims reserve to decrease the amount of money we're paying in actual premium to the insurance carrier. So it's kind of self-insuring to a certain extent the catastrophic losses internally. So that's something we're constantly evaluating through the Audit and Finance Committee and obviously through the Board of Directors as well.
All right, there was a lot that we covered there, and if as we work through other parts of this presentation, and you want to come back to clarify, please ask those questions. So now we're up to Beth and Ashley again.
Yep. It's a Beth and Ashley show. Great. So when we're talking about healthcare costs and growing faster than CPI, there's a couple things to point at, but one very obvious is supply and demand. So when you take a look at what's around you and what's available to you, the supply grows. So that's one thing to look at. Also, when you take a look at healthcare growing fast is technology. Technology advancement, pharmaceutical advancements. Technology is valued. We as consumers demand it, we expect it. We expect to have the newest, latest, and greatest technology without ever questioning price. Our doctors are trained and they know how to utilize it. Pharmaceutical breakthroughs on cholesterol, MS, cancer drugs, they all come at a price. So the push and pull also of federal and state mandates, taxes, and fees, policies that are changing within the healthcare roles in our industry are also impacting healthcare costs. So when you take a look at medical technology and advancements, yes, years ago we simply just got an X-ray. You had a mammogram, you had an X-ray. Now we have digital mammograms. We have MRIs, we have CAT scans. It's not just going in and saying, oh, I need an X-ray of my elbow or my knee. They're saying, oh, you probably want to get an MRI to see if we need to do surgery. Yes, it is a better view and technology is available. Your doctor's ordering it. Do we ever question it? Cancer treatments and therapies. Years ago, people actually passed away from cancer. Today, the success rate is amazing, but all at a cost. Joint replacement, hip, knee, they're a dime a dozen. They used to be very rare and very costly. Now, they're doing hip and knee replacements. Just in the last year in the United States, over 600,000. With the demands from working longer, obesity, there's a lot going on. They're projecting over 3 million knee replacements over the next 20 years. So numbers of surgeries, cost of care, there's a lot going on when you talk about that. Premature birth rates or high-risk pregnancies, the average cost of a premature baby is anywhere from $250,000 to $500,000, and that's just the first year alone. That doesn't continue on through their lives where there may be therapies. So as we look at technology, it is a wonderful thing, but it comes at a price.
And as technology increases and the costs continue to rise on the medical side, Beth mentioned how that does directly affect the prescription side as well, because while we see the specialty medications today, on average, having a cost of about $2,500 per script, we know that that cost is only expected to rise. Our prediction is a rise of about 20% on specialty drugs on average per each of our PROACT plans in the upcoming years, and we expect this rise to continue for at least the next 3 to 4 years. What is this due to? This is due to technology, treatment moving from the doctor's office in the hospital to someone's home, a place where someone is more comfortable. Now, with this increase in drug cost on these specialty drugs, we can't expect our members to pay co-pays of hundreds of dollars. So this cost gets averaged out through all of the other prescription drugs being filled, those generic drugs, all of the brand drugs. And what does it do? It makes the cost of the prescription drug plan go up as a whole every year. So with the technology and with people, having more access to prescription drugs that are more effective, are more powerful, keeps them out of the hospital, this is great news, but there's a cost, and it will, again, to piggyback off what Beth was saying, just continue to go up year after year. The things that we're seeing in the industry, that we see some drugs out there today to treat, but not as many as we predict in the future, will be for oncology, rheumatoid arthritis, CNS disorders, infectious diseases, and respiratory diseases. Some popular medications, as we keep talking about these high-dollar specialty drugs, would be Humira, the Humira pen, Stelara, most recently the hepatitis C drug that's been prescribed that's expected to cost, I don't know, somewhere around $90,000 per case for each treatment, but that will save the plans down the road if someone gets this $90,000 per drug treatment, because they won't have to pay for that liver transplant or in-hospital treatment, which can cost, gosh, $500,000 and up. So although this progression on the drug side is excellent, it's positive, ultimately you're going to see the cost just become, I think, more equally spread between the prescription and the medical plan.
Oops, thanks. Okay, state and federal mandates. As I indicated earlier, one of the pushes and pulls is actually the government within the health insurance industry. So believe it or not, from 1993 to 2003, there were over 30 new mandates applied to your health insurance. And this was without you asking for them. This was done at the legislation, and the insurance companies actually had to pull their hair out, because once they pass a law and they say, oh, well, child visits are covered, they don't define it. So what we have to do is take that and interpret it. And it goes to our legal counsel, and they determine what's age appropriate, what immunizations are going to be covered under that mandate. So not only does it cost to pay for the mandate, but it costs to actually review and get the legal opinion and turn around and rewrite contracts to make sure that we're covering it per the mandate that was passed. The other, from 2003 to just 2013, another 51 plus our PPACA passed, and that was healthcare reform. You can flip through that. I'm just going to touch on a couple of them. I talked about the well child visits. That happened in '94. You have the Mental Health Parity Act. Diabetic treatment, that is to be covered in 1993 as any other office visit. 1998, chiropractic care. You also have breast reconstruction. You have oral contraceptives, where we were not covering, the plan itself was not covering these costs. All of a sudden, that burden's put on the plan, and then having to readjust that as claims come in to cover those expenses. When you talk about an annual routine physical, good stuff, but before it was something that the plan didn't incur, somebody was picking that up out of their own pocket. You also have the contraceptive devices, chemical dependence, bone density treatment. These are all mandates passing throughout the years, should I say. You talk about some changes with healthcare reform. You had the dependents to 26. Now, that didn't seem that bad, because everyone kept saying, well, they're the young invincible. I call them the reckless crazies because they still cost money. When they go and they have a knee operation or surgery on their shoulder because they were doing some jump trick skiing, it all costs money. Luckily, in New York State, when we look at healthcare reform, some states had to rewrite their contracts from almost scratch. With the mandates that were passed over the last 20 and 30 years within New York State, we weren't that far off from healthcare reform. So putting dependent to 26, most of the policies had student to age 25. We actually opened the door. So where the plan was no longer taking that expense, we now open that exposure back up again. Another issue, which, it sounds minor, most of the policies that Excellus wrote and I wrote for the city and the county had $1 million maximum on there. And everyone says, well, $1 million, that's what I need to retire. That's the money, that's the dollar amount. $1 million, well, when you actually negotiated contracts years ago or when a lot of the policies were written, $1 million was so far off. But as Steve just spoke about, we've had $1 million cases, and they've been close to home right here in our backyard. So these cases are there. The cost of care, the advancements that we're seeing are pushing dollars up. And now you have push and pull with government adding stuff to the policy without asking anyone if they wanted it. Pros and cons, again.
Any questions on this section? Must be people are thinking about the break.
I'll
Please,
throw in one
Mary Ann.
question. Do you have any information to show that patient out-of-pocket costs have decreased as mandates have increased?
As a percentage or a fixed cost? I guess I'll ask you, I'm sorry, I know you're not supposed to answer a question with a question, but, because it's two different answers. From a fixed cost perspective, other than prescription drug copays, I think most people's out-of-pocket expenses have stayed relatively constant. I think in the prescription drug area, we've seen some increases in copay. In terms of as a percentage of the overall spend, it has actually gone down over the last couple of decades. Because as the plans have added benefits, the lion's share of the benefits that have been added have been no-cost share kind of benefits. Now all of a sudden we're picking up preventive care at no cost, well child care at no cost, mental health parity, where those used to be limited and have cost sharing, now they're equal with the health, and a lot of that stuff doesn't have cost sharing. So as the mandates have kind of piled in, we've seen an increase in the percentage of the overall claims dollars paid by insurance or the plan, and a decrease in the percentage paid by the member, even though the fixed dollar amount may have gone up slightly for them.
So we've got these three moving targets: the increased cost of health care, the increased mandates for health insurance, and maybe decreased out-of-pocket costs.
As a percentage, yes, I would agree with that statement.
Thank you.
So maybe you'll get to this, but I really want to understand exactly what the consortiums, where they fit in terms of contracting, let's say, with Excellus, because Excellus is a for-profit company, right? They're not. All right, well, the CEO last year made about $5.2 million.
They're a business.
They may be a nonprofit, but they're a huge business. But so they're making money for whoever they are making money for the organization.
Yes.
And the administrators who are in the organization.
Sure.
And it just seems to me that the savings we're seeing relative to if we didn't have the consortium, because we're spending 7% on administration, right? Everything else 6%. Everything else is going into the savings, into the coffers. So where is exactly the savings that we're getting relative to if we didn't have the consortium? Because it seems to me the premiums aren't so different if we didn't have the consortium, maybe 5% difference, if I'm not missing something.
So we're actually going to be covering that next.
Okay, good.
So, and part of the answer to your question will be, you have to be comparing the same plans.
Right.
So if you're not comparing the same plans, then it can be widely different.
But I think I was comparing similar plans. I mean, so I just really, that'd be great.
Okay. So we'll move right along then, to keep ourselves towards break. After a low point where some towns sued the county over land use issues, elected leaders sought to find ways to save taxpayers' money rather than having them pay for squabbles. We created what was called a Shared Services Task Force. And for those of you currently involved with local government, you've probably heard that term yet again. And one subject that gained some traction was trying to find a way to control health insurance costs, which was and still is increasing much faster than inflation. The goal was to pool municipal resources to provide insurance and benefit plans which are less costly and more stable while not compromising the level of benefits. So the health insurance became a focus of the Shared Services Group early on, and the Tompkins County Council of Governments was created to be an umbrella organization for the local governments to come together as equals. Through TCOG, it was agreed to look for a pathway to create a health insurance option that would allow all municipalities to participate. That pathway was through Article 47 of the New York State Insurance Law. The problem was that no one Article 47 had been created since the legislation was passed in 1993. The Council of Governments sought and then was awarded a Shared Municipal Services Incentive Grant for $250,000 to work through the process of creating an Article 47 insurance company. Creating a governance structure was no small task, and establishing a balance between large municipalities like Tompkins County with over 1,200 employees, with some small towns and villages having under 10 employees, took a lot of negotiation and creativity. But in 2009, the framework for the consortium was created, and we began submitting our application and soon discovered that the hardest work was yet to come. One task was to create a meaningful role for the consortium's decision-making, and that involving labor. The joint committee concept had been used by an Article 47 that was operating before 1992 and was grandfathered in. So our initial bylaws included and still do include a joint committee with the authority to adopt their own bylaws and the responsibility to review and provide guidance on any benefit plan changes. However, the New York State Insurance Department reading of the legislation and the bill packet that goes with it had demanded that labor have voting positions on the board of directors. Negotiations between labor, consortium designees, and the insurance department resulted in the current municipal cooperative agreement. But we weren't done. Municipal governments collectively had to post $1.22 million into a contingency reserve. To meet that requirement, not every municipality was able to ante up proportionately. So to reach that milestone, we helped each other out. And this was truly a remarkable example of municipal cooperation. Also, the insurance department required that the consortium build within the first year an IBNR reserve of 25% of the actual claims. IBNR is an acronym for incurred but not reported. So an easy example would be that if you started a procedure or became ill in November or December and your treatments were still going on for the next year and the claims hadn't yet been submitted, then those would be incurred but not reported. Raising premiums high enough to generate that much reserve in 1 year would have made the premium so high that no one municipality could make the case for joining the consortium. After much negotiating and pleading our case with actual claims data from both the city of Ithaca and the county, we were able to get the IBNR rate to 12%. And again, that was no small feat. We were awarded our certificate on October 1st, 2010, and we started providing insurance on January 1, 2011. With that 1.22 million posted reserve, we covered 4,400 persons that year, generating approximately $26 million in premiums and paying out $22 million in claims. The document that holds the consortium together is called the Municipal Cooperative Agreement, the MCA. It states the operational framework for the consortium. It affirms that the financial responsibility is shared between all the municipalities that are members on a prorated basis for premiums paid. It establishes a board of directors with one from each participating municipality, and at this time, 2 labor directors. And Scott was very humble when he didn't mention that he is actually one of those labor representatives when he went around the table. Each voting member has equal rights, except for there is a possibility for weighted voting, a weighted voting system which could be invoked, but only with a collaborative consensus. And I will report that to date, we have never used a weighted voting model. The MCA stipulates that the board of directors are responsible to direct and protect the consortium. It also creates the Joint Committee on Benefit Plan Structure Design, which has 1 labor seat for each bargaining unit, plus 1 for each municipality. The MCA also describes how municipalities can join, leave, and how the consortium would be dissolved. The Greater Tompkins County Municipal Health Insurance Consortium is an insurance company. Article 47 is self-insurance, but both the county and the city of Ithaca were self-insured before they joined the consortium, which means that they held 100% of the financial risk. However, the difference is they bought benefit plans from the private sector and only had their employees in the risk pool. The Health Consortium is different because we also write benefit plans and we can administer claims processing in-house, but wisely have chosen not to. We are certified to operate under Article 47 of New York State insurance law, which creates a special structure that allows large municipalities like Tompkins County to collaborate with small municipalities with under 50 employees. Steve Losey mentioned earlier that we pool the health risks for our populations of covered lives by throwing everyone together in one pool. Old, young, retired, we're all in it together, and we pool our premium as well to pay for the medical and prescription claims that come through. The premiums are set each year before the claims are actually known. This fortune telling is done through actuarial science. Actuaries love and use statistical science. So now you know if you're at a cocktail party and someone says they're an actuary, time to find another person to talk to. Using claims trend data from a long history as possible over a larger population as possible adds confidence to these numbers. Actuaries look at our consortium data as well as a broader population of data for upstate New York and the Northeast. The consortium hires Excelis to administer medical claims and Proactive administer pharmaceutical claims that our members incur. Later in the presentation, we will describe how that process works. But both companies, when they receive those claims, bill the consortium immediately for those claims incurred, and the consortium pays immediately for those claims incurred. The consortium maintains then 2 reserve accounts required under Article 47 for contingency and IBNR. The contingency covers the unforeseen, and the IBNR is a reserve in case the consortium ceases business. Then the claims that are in the pipeline will be paid by the reserve and not left as an unfunded liability. So you probably can't read this any place other than maybe on the screen, but you can also find it on our website. This is a organizational structure for the consortium. So all the municipalities and their employees are the main part of the consortium, and then a very small subset of that is the board of directors. And they have the responsibility for running the business. Reporting to the board of directors is the executive director, whose work is to support the work of the board as well as the committee, and to provide the energy for events such as the one we're having tonight. Reporting to the board of directors are advisory committees, and the term advisory is critical here to appreciate because the ultimate responsibility for all decisions lies with the board of directors. But advisory committees play an important role in providing deeper investigation ahead of a recommendation to the board of directors for action. Helping committees feel valued is a very important challenge for the board of directors. Also reporting to the board of directors are specialized consultants support consultants for finite tasks. We have an audit consultant, legal consultant, actuary consultant, and we have a very key consultant in Losi and Cahill who provide general business and our liaison with the other consultants. And finally, the Board of Directors contracts with Excelis and ProAct for administration of medical and pharmaceutical claims, respectively. So why would anyone go through the headache and the rigmarole of creating a health insurance company? Good question. It's actually because the consortium has more efficient operation model than the private sector, and I know you'll never hear that on Fox News. Pooling resources, also called collaboration, can increase efficiency, and in this case, it has for the consortium. It increases buying power because even the largest employer, Tompkins County, now has twice as big a pool of covered lives to spread its risks over. Health Insurance Consortium also reduces administrative expenses. By creating an insurance company, we now set the premiums for claims plus administration. The responsibility lies within the Board of Directors, which are all volunteers. So there are no 6- and 7-figure CEOs or marketing staff that we have to pay for. So most private sector health insurance companies are struggling to keep their overhead low enough to meet the 85% of premium to pay their claims, which is required by the Affordable Care Act. The consortium is running between 93 and 94%. This is an admirable and enviable efficiency. This is real savings that totaled $928,000 in 2011 and continues every year thereafter. When I was talking to Beth before the meeting, Excelis was actually providing the insurance for every one of our benefit plans before we joined the consortium. And she was negotiating, and we were all paying for the time and energy to negotiate contracts with Excelis, and now we negotiate one. So by having a risk pool of over 5,000 covered lives, we create stability for our claims prediction, so one expensive claim doesn't tip over a big apple cart as we have now. And what the Board of Directors does is not beholden to stockholders. Financial planning is for the benefit of the members, both municipalities and employees, with stable, predictable premiums, and for budget setting, and for those in the budget setting group, I see a couple of town supervisors here, the premiums are set actually in October 1, well ahead of adopting a budget. The consortium provides benefit plans, also called insurance products. Any change in benefit plan design is a conscious decision by the Board of Directors, except those that are required by state and federal law, which take place without our consent. The Health Insurance Consortium plays no role in contract bargaining. So this is a little bit hard to get our heads around because the players that sit around the consortium table are the same ones that sit around the bargaining table. But that is the case. So I'll repeat. The consortium plays no role in contract bargaining. All plans and financial data are reviewed and approved by the New York State Insurance Department, which is now called the Department of Financial Services. So there is an objective third party with very conservative standards reviewing our operations quarterly. Employees are represented in the process through our two directors that sit on the Board of Directors and through their bargaining unit leaders that sit at the Joint Committee. And finally, they can be involved personally by participating in any of the other committees that the consortium has. We strive for transparency. Please check out our website. All the information is there. All our financial data, the minutes of all our committee meetings, and our policies. It's all there. So this is it. This is where we are. 15 municipal employers. That's the county, 2 cities, includes the city of Cortland, 8 towns and 4 villages. 4 of them are large employers. 11 are small employers. We have approximately 2,280 total employees and retirees. That's over 5,000 covered lives. For 2014, we plan to receive in premium $37.8 million. This is a big deal. We are the only newly formed Article 47 since the bill was passed to allow them to be created in 1993. So with that, I'll take any questions that you might have, or anyone else in the panel. Please, Ann.
I'll search for this contract, but do towns have to re-up every so
So there's a process for dropping out. You're in until you tell us you're dropping out.
So I don't have to read it.
You don't. But we did, just this past year, make a change to the municipal cooperative agreement, and you signed that. So that's the only time that we will bug you, other than with the bill for the premium.
And just as one extra point on that, under Article 47 and actually under Article 5G of General Municipal Law, there is a requirement that the municipal cooperative agreement has to be renewed every 5 years, and there's a provision in the agreement for that renewal process. But the individual municipalities aren't required to take any action. It's the board of directors that really takes the action, just to renew the agreement. So we will definitely remind you if you need to do anything. Yes.
We have Michelle.
Other questions? Please.
On the slide, starting the GTC and GTC, your last bullet, it looks like we collected 26 million in premiums and paid out 22 million in benefits.
That's correct.
So there was 4 million. Did that go into reserves and was used for admin as well?
So the question is, on this slide that's ahead of you, there's a difference of $4 million between the premium that was collected and the benefits that were paid out. And this was the first year, and this, if you may remember that I mentioned that we had to raise an IBNR reserve during that year, which was over $3 million. I think it was 3.4, something to that effect. So 3.4 million of that went to the IBNR reserve, and the rest would have been used for paying the administration. We do pay a fixed fee to both Excelis and ProAct for the administration of the claims. So, yeah. And we do generate some fund balance each year, which is good. And the reason it happens is because we are not having claims that are exceeding our budget. They're typically right at or just below, and so it allows us to build a little fund balance. But this is statistics, and not every year will be so lucky. Sure. Other questions? Please, Michael.
Don, are we expecting any other municipalities to join?
We are not expecting, but we are, MCA allows for municipalities from adjacent counties to join, so that's why the city of Cortland has. Both Steve and I have had inquiries on a regular basis from adjacent municipalities that are looking us over. So since we've joined since we started, both the town of Lansing and the city of Cortland have joined, so we've had 2 municipalities join us from the original 13 group. Sorry I didn't repeat Michael's question for the video people, but hopefully you can catch the gist of it from the answer. Anything else? Okay, then we're moving on to the slide we were looking for, which is break. So, please.
Get back to Mike's question and your answer. If the consortium were to actively reach out to invite more municipalities, presumably it would have an even bigger number of people that would presumably risk further. Could that reduce our costs more, and is the consortium looking at that?
So the question was, is the consortium doing any marketing to expand the size of its group? And the answer is that would be a decision of the board of directors, and so far they have not directed either Steve or I to do that. The question then further went on, would there be a savings? If you take the efficiency of this model, which is 93 to 94% being spent on claims, then the only efficiency would come from the administration side of it. Steve would probably still work the 20 hours a day that he does for the consortium, and the other members would do, the support staff would do the same. So there may be some efficiency, but it's not going to be in large numbers. What will happen is with the claims costs that can be variable, the larger the group, the more closer they're going to be to the predicted value as opposed to being, having a wild swing. One of the reasons why the city of Ithaca joined the consortium is because they had such a small group, and when they had a large claim, it would drive their claims way up and down, and they were seeing huge swings that they couldn't really budget for. So having a large group adds to the stability.
The premium would go down for policy with a larger group?
I'm going to let Steve jump in on this one. Please take it.
Oh, yeah. Would the premium go down with a larger group? The answer to that is probably no, it probably wouldn't. The reason for that is we have a group now of, as Don mentioned, over 2,000 contracts, over 5,000 covered lives. You probably wouldn't see a direct reduction in expenses as a result of additional municipalities joining, but I think Don hit on the point that was critical, and that you would see more stability over time. So we would see less dramatic fluctuation. We would probably end up much closer to our projected budget, and through that process, you could see future savings, but not, I wouldn't think we would see any type of immediate initial savings, especially when we're talking about most of the municipalities that would join at this point are probably smaller in size. So it would take a large number of them coming in to really alter our numbers significantly. Even though the city of Cortland is fairly large, they only added about 300 contracts to our total population, so it wasn't a huge swing from where we were. So my gut sense, not having evaluated, depending on who it is, obviously, looking at some of their risk factors, no, I wouldn't anticipate seeing a big decrease in expense related to premium as a result of more people joining it from initially. But again, in the future, more stability leads to future savings, and hopefully that would help the municipalities that are currently here as well.
All right, so let's take a break. We'll start back here in 10 minutes, which would be a little about, well, we'll start at 25 after. But if you get back sooner, then we'll get started sooner and we can get out of here sooner. Thanks. Enjoy. Okay, moving right along. Steve, what are benefit plans?
Thanks, Don. We talked a lot about health insurance, and obviously one of the key components of health insurance is the benefit plan itself. And there's really not a lot of definition out there in terms of what a benefit plan is. Most people just think of it as, when they're thinking about what services they need to have rendered, they'll look at the plan and get the description and see how it's covered. But basically, in terms of definition, a benefit plan is a contract, again, between a person and or their employer and a licensed health insurance company that lists the covered medical services. So when you think about your benefit plan is really the listing of what is covered or what is not covered. So that health insurance certificate, that summary of benefits and coverage, any type of summary plan description that you have or insurance certificate that describes the level of benefits that you get, that's really referring to your benefit plan. Now, in terms of one of the major components of a benefit plan today, it's the participating provider network. Beth talked a little bit about out-of-network expenses and what that meant. But basically what the insurance company does, or in this case, Excellus Blue Cross Blue Shield, does for the consortium in terms of our benefit plans is they go out and negotiate deals with the hospitals, with the physicians, with any type of other medical providers, so that the rate that folks pay, or the benefit plan pays, is a discounted rate off of the normal market rate, if you will. And they do that not only here locally, but they do it regionally in terms of central New York. And then coupled together with the other Blue Cross Blue Shield plans, we have access to all of their network discounts throughout the nation. And from a pharmacy perspective, ProAct does the same thing. They go out and negotiate deals with the various pharmacies, so we pay a discounted rate on prescription drugs. So one of the significant components of any benefit plan is the network of providers, facilities, pharmacies, physicians, et cetera, that make up your coverage. Who can I see for services? What am I going to pay? Obviously, that is greatly dictated by whether or not the person is in or out of network. In terms of the level of benefits, they can vary widely from plan to plan. But one thing I will tell you is that especially in New York State, there's a very finite definition of what benefit plans have to contain. So if you want to offer health insurance that includes hospital coverage, if you go to the New York State insurance law, there's a whole section of law that's dedicated to telling you what you have to cover in order to be called a hospital insurance plan. If you offer medical surgical, same thing. If you offer major medical, same thing. It gives you the list of minimum benefits that you have to provide. Now, today, we have the Patient Protection and Affordable Care Act that has another level of essential benefits. They refer to them as the Essential Health Benefits, EHB. And from a federal perspective, that tells us if we want to offer a health insurance plan, there's a certain level or minimum standard in terms of the coverage that has to be afforded to people. So now, when Beth referred to the fact that in New York State we're kind of lucky in that we already had a pretty robust set of state regulations and mandates, when the federal law came into effect, we didn't have to have a lot of change to our coverage. In other states, it was a significant change. You know, in other states, they may not have had the same coverages that we have here in New York State, where we've added preventive care for children or well child visits, immunizations. We've added a lot of things over the years with regards to mental health parity and some other things. In other states, they didn't already have that. So when they had to meet the essential health benefits, they had to add all this new coverage. So when you start hearing about insurance plans that are increasing by 40, 50% in premium, it's because of a lot of these benefits that they had to add to their programs in order to comply with the requirements of the Affordable Care Act. In terms of the different types of benefit plans that are out there, it's a pretty wide array. It's kind of like an alphabet soup of health insurance, if you will. Years ago, we had old style, what we refer to as traditional or indemnity benefit plans, where you would have 100% coverage for inpatient hospital, outpatient hospital, and medical surgical services, and that would be coupled with some kind of a major medical coverage, where you would have an upfront deductible and it would pay 80%. You would pay 20% till you met some cap, and then everything would become 100%. Those types of benefit plans, although they still exist in this consortium, are pretty rare out in the normal health insurance marketplace today. If you look nationally, indemnity plans are kind of on the lower end in terms of percentage of participation. Most people have moved to what we call preferred provider organization plans or PPO plans. The basic difference there is instead of having deductible and co-insurance under major medical for certain services, now we have co-pays for certain services, a fixed dollar amount, $10, $15, $20, whatever the case may be. Point of service plans, those are kind of like PPOs with no out-of-network benefit. So when you have a PPO benefit program, if you go in-network for service, you pay a copay. If you go out-of-network, it may be a different benefit level. With a point of service plan, those typically had no out-of-network benefits, and it typically had some kind of a gatekeeper, some kind of a preventive care provider that you would have to go to, and they would reference you out for care and things of that nature. We don't have any of those plans currently in the consortium, but they're certainly available out in the open marketplace. Obviously, health maintenance organizations have been around a long time, although they've evolved substantially from what they once were to what they are today. And today they're more in line with like a point of service plan, to be quite honest, more than an HMO like they were back in the 70s and 80s. High deductible health plans, those are health plans that have, as the definition would dictate, kind of an upfront deductible. Typically it's a fairly substantive deductible of greater than $1,500 for an individual. So it's a pretty substantial deductible that you would have to meet before any services were covered. Those plans typically are coupled with a health savings account, an HSA. In order to have a health savings account, you have to have a high deductible health plan to qualify for those. If you don't have a high deductible health plan, you could get a flexible spending account program or an FSA to be coupled with your health insurance, and it's a way for you to provide or pay for medical services with pre-tax dollars. In terms of one of the biggest misconceptions I think that's out there relative to benefit plans, health insurance in general, it kind of dovetails on the discussion we were having earlier about some of the different things that have been added to health insurance, state mandates, federal mandates, technologies, et cetera. Although a lot of times, and Don mentioned the fact that, you know, all of you folks here are involved in one aspect or another in the collective bargaining process. Although our collective bargaining agreements or our personnel policies in an employer may reference a specific health insurance plan by name, and it may be language that we've had in a collective bargaining agreement for 5, 10, 15 years. The reality is, even though that language is kind of static, health insurance or benefit plans are not. They're dynamic. They're fluid. They're changing every single day. Whether it's a new mandate that's been passed at the state or federal level, or it's a new medical technology that comes out that we now have to cover, health insurance is an extremely fluid item. And when we had the discussion about, percentage of cost or the level of cost and whether or not it was increasing or decreasing, a lot of that has to do with this change in health insurance. What it was 20 years ago and what it is today and what it'll be in the future is dramatically different. And a lot of that has to do with the fact, again, that these new medical procedures. We talked about some of the stuff that's been added. Obviously, those get woven into the product. If we cover surgery, as an example, it really doesn't define what surgeries we cover in the benefit plan. It just says we're going to cover surgical procedures that are medically required for your treatment of your illness or your injury. So as new medical procedures come out, new surgical procedures come out, they just get added to those surgical codes. And all of a sudden now they're part of the benefit plan. So when Beth referred to joint replacements as an example, 30 years ago they weren't done. They didn't have the technology. Today they're fairly routine. We have the technology. The technology is getting better and better. The joints are getting better and better that they're replacing. So we're seeing a lot more of that, and it's just one of the things that we see as a change in benefit. If you look at an insurance contract or benefit plan from 30 years ago, it might have referenced an iron lung. Well, we don't have iron lungs today. So these benefit plans have kind of evolved over time. What plans are available through the consortium? We do have a limited number of benefit plans. We have a specific menu of plans that we have available. The genesis of that really was the formation of the consortium. When we initially started the consortium, the goal today still is that we would provide benefits that met the needs of the employers and the employees based on what's been guaranteed to them either in collective bargaining agreements or personnel policies or legislative action. We still have that requirement today, so when we built the consortium, we had to have benefit plans that met the needs of every single municipality. Now we've added a couple. Recently, most recently we added one that kind of fits the model of the Affordable Care Act in adding a metal level plan referred to as a platinum plan. We're looking at adding other options in hopes of encouraging other people maybe to join, having options available for current employers to negotiate to or employee groups to negotiate to, but to certainly keep that benefit plan menu evolving over time. And that's one of the goals of the consortium. In terms of how you would effectuate change if you wanted to, obviously, first and foremost, you would have to agree to benefit change through your collective bargaining process. And again, if it's a non-bargain group, it would be through a legislative process or a personnel policy. So once you agree to the change could be made. The consortium, as Don referenced, cannot unilaterally make benefit changes. We do not have the ability to override or supersede any type of legislative action or collective bargaining agreement language that's in place. Each municipality currently has their own group number. They have their own group structures. Quite frankly, inside many municipalities, we have multiple group numbers and group structures. If you want to add a benefit plan, really all you have to do once you get to agreement, contact Beth Miller at Blue Cross Blue Shield and Ashley at ProAct. They will make sure that the benefit changes are made. The only thing that we would suggest is that when you're doing that, also obviously make that communication to the consortium so everybody's on the same page, and allow at least 60 days for that change to occur. There's a lot of work that has to be done behind the scenes to make sure that the right people have the right benefits. So we want to make sure that we have everybody situated with the right ID cards and everything. So do allow enough time in your process to make those changes.
All right, Ann Ryder, did you get your question answered? All right. You were asking about indemnity and PPO.
What's the difference between an indemnity medical plan and these PPOs, besides they're more expensive?
The basic difference, the indemnity plan for things like office visits, durable medical equipment, medical supplies, those things are subject to an upfront deductible Could be $100, I don't know which plan you're looking at on the sheet, but it could be $100 upfront deductible, and then the patient has to pay 20% of the cost of the item or the covered benefit of the item up until they meet an out-of-pocket maximum. With a PPO program for an office visit, as an example, the person may only have to pay a $10 copay. So it's a little bit different setup in terms of the benefit plan structure. And for instance, under the PPO plans, there may be copays for things that there aren't cost sharing for under the indemnity plans, but we could certainly get you a listing, side-by-side listing, if you were curious, of what the different levels of benefit are. Yep.
Any other questions? Mary Ann?
The only unilateral-ish change that we hear comments occasionally from employees about is the extent of the network. And let's see, with Excellus it'd be the network, and with same with PROACT, with which drugs become preferred or not preferred. Those do seem to change without our knowledge.
Yeah, unfortunately, in terms of the benefit plan refers to the participating provider network. It doesn't refer to the actual list of providers. So that is fluid. There's no question about that. And I will tell you, it's one of my personal opinions and based on experience, I think we're going to be running into a period of time in the next several years where you're going to see a lot more discussion about contracting and provider networks as pressures continue to mount from Medicare and Medicaid, reducing payments to hospitals and physicians, insurance companies trying to negotiate reasonable rates of payment. I think you're going to see that a lot more in the news in terms of a provider network or a physician group that may cancel a contract for leverage and bargaining, things of that nature. Those are definitely fluid. And actually, I had a call the other day from an individual who said, is there any requirement on an insurance company or the provider to notify patients when they're in or out of a network? Unfortunately, there's not. I will say to you that when you go for service, certainly to a physician's office, look around, because a lot of times they'll post notices if they have changes in their network or who they're accepting, if you will, in terms of patients with insurance. But unfortunately, there's no overt type of notice that goes out to people to say, hey, Dr. Smith's no longer in the network. You may want to consider finding someone who is in the network. The patient, the covered member is going to have to do some homework in that regard, unfortunately.
So back to my first question. So we now have this platinum plan we could offer. I think it was like $17,900 for a family plan, somewhere in that neighborhood.
I don't remember off the top of my head. I think it's below that, but
17.4. It was something in the 17s. But it should be easy now to say, well, Excellus or some other plan, or the Affordable Care Act Platinum Plan, costs X.
Right. I know that the rate that we have in the consortium is below the rate that the Blues are selling that same exact plan for in Tompkins County to small employers. That much I do know.
By how much?
Off the top of my head, I don't. But I could certainly get that to you. I want to say it's at least 10% lower.
Good.
So this is really getting into the meat and potatoes of health insurance. Any other questions? Ann?
You have that platinum plan on there?
The Platinum Plan was just adopted by the Board of Directors. And so, Steve, when will that be available? Beginning of January 1?
It's definitely available for January 1. We'll have the information out in the next couple of weeks in terms of the benefit level and the rate. We'll issue that publicly.
Okay, Ann?
And the other thing, is there Medicare, what I call wraparound plan that's offered by the consortium?
Question is there a Medicare supplement plan? And there is. It's also been adopted by the board. I believe it's available now.
Yes, September.
It is.
September 1st.
It is very recent. September 1st was the.
So it's not.
Right, it's not on that reach.
So I'll also make you aware that the consortium has two other opportunities, although they're not covered through the consortium, it's just a pass-through, and that is for dental and vision that you can pick up. The consortium is hosting those policies. They're through CSEA, and it's a Duchess plan for vision, or for dental, and I forget who it is for vision, but at any rate. So if you're, as far as collective bargaining, whether you're, whichever side of the table you're on, that is an option that can be purchased through the consortium. It's a large group opportunity. Please.
Just to follow up on that vision and dental, our employees are not unionized. Would they be able to participate in the CSEA-sponsored coverage?
Yes, they would. It's being purchased through the consortium. So, but it's a straight pass-through, and it's not anything that we do actuarial, science, or anything else on. It's just a straight pass-through. But it is available for anyone who's buying health consortium insurance. That is an option. Okay, I think we're going to move on then to our next section, which is using the benefit plan. And this is the Ashley-Beth combo again.
Thank you. Thanks, Don. You can flip that. Okay, so actually what we wanted to do is give you a little flow chart of an actual claim. So when you think about healthcare,
You tried to simplify this, right?
Yes, yes. I got a headache. What do I do? Do I take an aspirin? Do I call the doctor? How much is this going to cost? So when you take a look at this flow chart, we really just kind of wanted to give you a visual. There are common questions to ask your doctor. Your doctor is your first line of defense. That is the person that knows you the best. That care that you receive in the doctor's office is the lowest costing service, typically out of your pocket and to the consortium. So although you may go to the doctor and show your Blue Cross card, the rest of the claim is being billed to the consortium. Just like showing your ProAct card, you may not always ask for a generic, but these are conversations that you should be having with your doctor because the cost of the prescription drug minus your copay is what's being billed to the consortium. So as you take a look at that, the claim comes into Blue Cross Blue Shield or ProAct. We determine if it's medically necessary and that it's covered under your plan, and we process it according to your plan. We pay our participating providers or getting the network discount through ProAct at our negotiated fees, and then we turn around and we pay our doctors and hospitals, and then they will bill you for any co-payment, or typically at point of sale is your prescription drugs where you pay your co-pay. As you noted, most likely as Steve indicated, when you're going to your provider, they're letting you know if they're participating or not. And that is a very hot topic, and that is going to be changing. You will see notices about doctors or pharmacies or hospitals that may become participating or non-participating. And that is something that is fluent. It's not a guarantee that just because your doctor accepts Blue Cross today, that they will be in the network. We work hard on your behalf to get the lowest negotiated discount that we can. And same for Ashley. It's a very complex negotiation that goes on. So when you think about that, you always want to check, are you participating? Is the pharmacy participating? How much is that drug actually going to cost? I may have a $5 copay, but that drug costs $1,500. So think about that when you're going to the use services the next time. Flip through. And then the other portion that happens back at the camp is the claim actually goes through an adjudication process, and that is determining whether it's necessary, how to process and pay the claim. Is it bundled, unbundled? Should we accept this? What's the copay? What's the deductible? But the other thing it also is checking for is it goes through an enormous amount of checks and balances. And the checks and balances that are covered through that are the same checks and balances that some of your recertification process that is happening at your municipalities starting this year. I know Judy and I have gone out and made a road trip visiting everyone to make sure that they're verifying who should be on the plan is on the plan. Because the one thing with your consortium, it's your consortium. You want to be paying for claims for the people who should be covered, not who are not covered. So again, part of the checks, balances, and audits that happen during your claim processing.
And as Beth mentions that claims process occurs back at the camp for Excellus, another key point to keep in mind is for that PROACT plan for those prescription drugs, that whole process outlined on this slide, 1 through 6, is happening right there at the point of sale. So as the consumer who's told, hey, how much do I owe? And, maybe the pharmacist says, it's not covered, or, it's some odd amount that doesn't make sense to the member. It's important to encourage our members to ask questions. Was my drug not denied? Does it just require a prior authorization? So much of the time, the pharmacists are so wonderful, or the tech is so wonderful in telling our members the reasoning behind the dollar amount that they're charged, especially if it doesn't seem right, if it's not what they're normally used to paying. So it's important to, keep our members educated with, the questions they should ask, awareness of their benefits, and of course, promoting them to not be afraid to call PROACT after they've picked up their medication, because they can certainly find out what's going on the back end, even though it's after they've already picked up their medication.
Okay, questions on how our benefit plans are administered? This is all work that we hire done through PROACT and Excellus, but it's important that we understand what's happening because this is where 93% to 94% of our money is spent. Right, moving on to Steve Losey about the consortium growing larger and stronger.
Thanks, Don. Yeah, we did put some slides together. I'm not going to bore you with going to a great deal of detail on all of them, but this handout will be available electronically, so you have this. Because we do think it's important for you to have an understanding of where we started from and where we are today, and where the money comes from and where it goes in terms of income and expenses with the consortium. And the first slide just gives you monthly contract count, and then also total number of covered lives. So all the covered members under the program, you see we added about 800 covered lives since the beginning, and that, again, predominantly had to do with the addition of the city of Cortland and the town of Lansing. And in terms of who is in the consortium, Don mentioned when we were first starting out with the conversation in terms of the development of the consortium. When the consortium first formed, we started with the definition of it was going to be municipalities only inside Tompkins County. And then we got a inquiry from the city of Cortland, and the board of directors decided that we could expand the definition to any municipality that was in a county contiguous to Tompkins County. So we started out with 13 municipalities within Tompkins County. We now have 15, one of which is in Cortland County. The other municipalities that would be contiguous would include the counties of Cayuga, Chemung, obviously Cortland, Schuyler, Seneca, and Tioga. Current list of members you have before you. I'm not going to bore you with reading that. Obviously, you can read it on your own. The next slide gives you an idea of where we are from income, and this is all the different kind of buckets of revenue that the consortium receives. And you can see that we've gone from about $26 million in premium income to about $34.5 million in premium income over the years. And obviously the premium is the lion's share of the dollars that we take in. Don mentioned early on about the capitalization investment, that $1.22 million. You see that about midway up the chart. I'm happy to report that the consortium was able to pay back that investment to all the municipalities before the end of the third year of operation, when it was originally built in to the 5-year pro forma that we would pay it back after the 5th year of operation. So that was certainly good news from that perspective. In terms of the distribution, I mentioned that medical insurance premiums are obviously the biggest component of that at 98.74%. From an expense perspective, claims is really where the the rubber meets the road, so to speak, in terms of what happens with our budget from year to year. We've gone from about 22.8 million in claims to now about 28.5 million in claims, and growing every year. You can see that the other components dwarf in comparison to claims, and collectively, if you look at the next slide, you'll see that for this current fiscal year through July 31st, about 93 cents on the dollar is going out to pay benefits for the members, and about 7 cents on the dollar is going for everything else, including admin, stop-loss insurance, any type of professional services that we do get, ancillary benefits that are also included in the package. That all rolls up under that 7%. Just to give you an idea of monthly paid claims, this goes all the way back to the beginning of time with the consortium, from the infancy of January of 2011 through the end of July of this year. About 74% of our total expenses on claims are related to medical claims, and about 26% are directly related to prescription drug expenses. That wild fluctuation there at the end just had to do with some system conversions at the Blues. They've since finished that, and now we're back to a normative level over the last couple of months. In terms of how we're doing budget versus actual, this first slide shows you on a month-by-month basis how we've done throughout the time frame. Now, it looks like there's a bit of fluctuation there, and there is. Obviously, it oscillates from month to month depending on, did we pay 5 weeks worth of claims in 1 month or 4 weeks worth of claims? Did we have a large loss in there? Did we have a couple large losses, et cetera? Did we have a claims system conversion at the Blues? All those things kind of weigh into that. But if you look at the cumulative chart, other than that one anomaly towards the end, we've been within less than 1.5% of our projected budget from day one with the program. We're about 1.5% below budget for the entire history of the program, dating all the way back to January of 2011, all the way through July of 2014. So from a prediction perspective, we've been pretty good at staying within budget, and we've beaten the budget a little bit, and that's one of the reasons why we have generated a bit of net income over the years. In terms of the distribution of that net income, here's where the money goes. And one of the advantages of having an insurance program like this is that if we don't meet our expectation in terms of expense, any profit, if you will, or premium over expenses stays within the consortium. It doesn't go to an insurance company or to some private corporation. It stays right here within the municipalities. All the municipalities proportionally own that money. It is invested. We earn interest on that money, so that does help keep the expenses down, although we're not earning much interest these days. It does help a little bit. But we do also have reserves that we have to maintain, and we talked about the incurred but not reported claims reserve, which currently equals 12% of expected incurred claims for a year. We have a surplus account that we have to maintain that's 5% of premium each year. Those are mandated statutory requirements. We cannot fluctuate from those. We did develop a catastrophic claims reserve this year. It's not reflected in this, but you'll see that in 2014 when we get to the showing the financial results for this year. And then we also do have an unencumbered balance at the moment. At the end of 2013, it was around $6 million. That money is there for us to use in future budgets to help mitigate rate increase. So unlike an insurance policy where that premium dollars that you didn't spend is lost, we get to retain that in the consortium, and then we can apply that against future budgets to help mitigate rate increases down the road. And that's something that we are certainly looking to do as a consortium as we move forward. In terms of trying to give you some comparative analysis, and it is difficult because especially for the large employers who were experience rated, there's really no source out there that we can look to say, okay, they're paying the same rate that this group was paying at that time. What are they paying today? What are we paying today? There's really no item or group that we could really bounce that off of and say, are we doing good or bad? For the small employers, we do have a group. We do have Excel's Blue Cross Blue Shield's own data in terms of what they're charging their community-rated programs. And you can see when we started the consortium, we were at 9.5% the first 2 years, then 9%, now 8% in 2014. Right now, we're looking at an estimated 5% increase in 2014. or 15, I'm sorry. Our weighted average is about 8.2%. When you look at the weighted average for the small group market for the Blues, over that same time period, they're at about 11.4%. Now, the 1 year, 2014, it was very difficult to get this information because everything changed. The Blues had to get rid of all their old model community-rated programs, adopt all new models based on the Affordable Care Act, and implement those. So there really wasn't a filed rate change for the year. It was really a filing of an entirely new rate manual. So we do have 2015 data. Right now, their weighted average increase that they were awarded by the New York State Department of Financial Services was 12.2%. That's below what they had requested. I think it was 4% below what they had requested. So they actually requested something in mid-teens and was awarded 12.2%. So based on our increases compared to the community-rated market, for the small group employers out there, and which is predominantly our towns and villages, you can see that the consortium has done well by you. And not only are our rates of increase lower than what the market rate is, when you initially joined the consortium, most every municipality received a little bit of a break on premium initially because the rate the consortium was charging was below what the going rate was in the marketplace as well. So that gives you a little bit of idea in terms of where we are from a perspective on the consortium. How do we measure up? Does anybody have any questions? I know it's a lot of information in there about statistics and finances and things of that in terms of the consortium. Yes?
What do you pay taxes to?
Believe it or not, every health insurance plan, and the question was, who do we pay taxes to? Every health insurance plan in the state and in the country has to pay fees and taxes. In New York State, whether you're a self-insured plan or an insured plan, there are two predominant taxes that we pay. There's one called the graduate medical expense, and that is a sum of money that the state collects based on a per contract, per month basis, and that goes to teaching hospitals or to help subsidize teaching hospitals. We also pay what they refer to as a Healthcare Reform Act or HCRA fee, which is a surcharge on all inpatient, outpatient services, diagnostic services, lab, x-ray. That is about an 8% surcharge on top of the actual billed amount that we get from the providers. That's built into the payment, and it goes directly to the state for covering indigent care through the state pools. So those are two state taxes that we pay. Through the Affordable Care Act, we now have to pay what's referred to as a Patient-Centered Outcomes Research Institute fee, which is a per covered life per year fee that we have to pay. It's $2 this year per covered life. We also have to pay what's called a transitional reinsurance program fee this year to the federal government. The cost of that is $63 per covered life for this year that'll be paid to the federal government. So those are really the lion's share of taxes and fees that we have to pay.
They go to a specific fund,
Yes.
not in the general revenue.
Yes. In theory, yes. That's exactly what they're supposed to do. Yes. Well, I mean, I'm never 100% sure where any of my tax dollars go, so who knows?
So I know we've spoken quite a bit about specialty medications in your prescription plan, but I think when we look at today at the consortium, when we look at the future, again, you know, we don't see the cost for specialty drugs to do anything but rise, especially in the next few years, at about a rate of 20% each year. Today, our members are spending around $13.10 for their specialty medications, and that's taking all of the different groups within the consortium and kind of averaging out what copay would be assigned to where a specialty drug would fall based on a 3-tier setup. Most of the time, a specialty drug is a tier 2 brand name drug, but considered specialty. We show you the generic, not the Wikipedia definition of specialty medications, but I think a very good definition of what we talk about with specialty medications: high-cost oral or injectable medications used to treat complex or chronic conditions These drugs are predicted to become more prevalent as treatment is moving more and more to an in-home setting for conditions requiring specialty medications. I know we've really beat that to death tonight, but I think a major challenge is just taking a look at these costs and maybe even being open to offering a benefit plan that might have one day a higher copay for specialty drugs, as we do know specialty drugs alone are about 10 times as much as the average drug filled by your plan members today. That would be a recommendation that we would make, as the best way to help control cost for the future. Maybe putting a little bit more of, the member's skin in the game, potentially, working to get more assistance from pharma where possible. Pharma is a kind of a prescription world terminology phrase for, the drug manufacturers out there. There are programs today that offer co-payment assistance to members who are charged, a certain dollar copay and up. That's something that we're always looking at, and even if a member has a $5 copay today, there might be a program being offered by the manufacturer that would waive that copay. I can say that when members today are filling their prescriptions through Noble, which is the specialty drug pharmacy owned by Kinney, which also owns Proact, or kind of all together in this, we are automatically looking to see if there's any other way to help cover the cost of the drugs, which sometimes there is and sometimes there isn't. And again, I mentioned Noble being our specialty pharmacy. You may or may not have heard of Noble before. If anybody's been present for any of the prescription plan reviews that I've presented, we've definitely talked about it, only because so many of our specialty drugs are being processed through that pharmacy. It is Proact's in-network preferred specialty drug pharmacy, but you should know that any specialty drug pharmacy that is in-network with Proact can be used, and there are multiple ones out there. Not every specialty pharmacy has the ability to fill any specialty drug. They have to be approved by pharma to dispense the specialty medications that they are supplying. And outside of the drugs actually costing more to your plan, they actually do cost a lot more to whatever pharmacy is dispensing it, because specialty drugs can only be dispensed through approved specialty pharmacies that have the right conditions, such as, different levels of refrigeration, the right pharmacists. Pharmacists have to have a special level of training to dispense specialty drugs that is different than just a regular drug. So outside of the drug costs increasing year after year, causing your plan to pay more for this classification of drugs, it also costs whoever is dispensing the drug a lot more to provide the members these medications, because they are so sensitive, expensive, and highly guarded.
Thanks, Ashley.
You're welcome.
Looking at all the pictures up on the screen, there's quite a lot to talk about. However, I will knock it down a little by simply saying economic pressures will force new innovations and solutions to healthcare. You will see changes in the way you access care, the types of services you are receiving, virtual, electronic, medical records. It's all set up to improve clinical workflows and outcomes. There's going to be remote access. You may even be sending your doctor from your iPhone your medical records that you're keeping and you're storing yourself, so that by the time you get home, you can have a televised conversation with the doctor who's reviewing your tests that maybe you stopped in the morning and had lab work done. So it's all changing. There's science and engineering disciplines that are interfacing to provide new advancement in medical treatments. There's robotics, there's computer science, mechanical engineering. what they do with fabric, bioengineering. There's the applications on the iPhone use that I spoke about. And instead of just talking about implants, liver and kidneys and hearts, maybe they'll be growing new organs for us instead of just implanting somebody else's. So lots of things to come. It's the future. It's wide open.
In terms of some of the other challenges that we have to face as we move forward, obviously the Affordable Care Act is an ongoing implementation. It's an ongoing transition. This year alone, we had the individual mandate to purchase health insurance that came in to the marketplace. The health insurance exchanges were obviously rolled out, along with the premium and cost sharing subsidies. The employer requirement we're going to have to satisfy in 2015 for the large employers. For small employers, will be 2016. We have some conversation around wellness. Obviously, the Affordable Care Act allows wellness rewards, so that's something we're taking a look at. And then we talked about some of the taxes and fees, and I do have a little bit of information that I'll just provide you with that here in a second as well, just a little bit more detail. In terms of one of the things that we're trying to deal with our clients, obviously the consortium has already delved into this to some degree, is making sure that we're set up in such a way that we're competitive with what's out and available in the marketplace. And obviously, the implementation of the Affordable Care Act has altered that. As I mentioned, when we were looking at the community rating filings of the Blues, they had to completely revamp all of their plans and file them as if they were brand new plans this year to meet the individual mandate. The plan structures that are out there now all fall in line with what the Affordable Care Act refers to as an actuarial value, or an AV. And simply what that means is if you take a benefit plan and basically put the benefits into an evaluation model that they've developed, it'll return the amount of care that will be covered for the average person based on that benefit plan. So for an average person under a platinum plan, the benefit plan is expected to cover about 90% of their total medical care costs for a given year. A gold plan would be 80, silver would be 70, and bronze would be 60. The minimum requirement under the Affordable Care Act is 60%, or the bronze level. One of the new plans that was adopted by the Board of Directors was a platinum plan model that will have an actuarial value today of the 90th percentile, if you will, and into the future will maintain that actuarial value. So it will change in terms of the benefit plan over time to keep that cost sharing or that cost relationship in line. In terms of the ACA taxes and fees, I mentioned what those were this year in terms of the Patient-Centered Outcomes Research Institute fee, the Transitional Reinsurance Program fee. The one that I didn't mention is the Cadillac tax. So the next couple of slides provide you with the detail of those two taxes, and you can certainly read them at your leisure, if you will. And again, this will be available to you electronically, so you have that as reference materials. But one tax that potentially is on the horizon, and I say potentially, it's in the Affordable Care Act, and unless there's legislative change to alter it, it's going to happen. And that's referred to as the Cadillac tax. But basically in 2018, if we have an individual plan that exceeds $10,200 in premium for the year, and that's aggregate premium, employee and employer premium, and family coverage that exceeds $27,500, for each dollar you go above those limits, you're going to have to pay a 40% excise tax to the federal government. So that's a real issue that's hanging out there, and one of the reasons why we're looking at trying to develop some lower cost alternative programs that will be available for negotiation if employers need those, if their plans are going to exceed those levels. I did provide an example on the next slide of one particular program and what it would exceed the levels by in 2018 based on some modeling that we did based on an overall 8% increase over time. Obviously, if our rate doesn't go up by 8%, it may stretch that out or minimize the amount of excise tax. But suffice it to say that it's a real issue that we're looking at and something that we need to at least be aware of that's out there on the horizon in terms of additional impact of the Affordable Care Act down the road. In terms of future, yes, I'm sorry.
Who pays the tax?
The health insurance plan pays the tax, which means the consortium would have to pay the tax. However, at least it would be our recommendation, and certainly internally in terms of discussions, that would be levied back against the employer that has the high-cost plan. It would be unfair to ask all the other members of the consortium to reimburse a fee on behalf of one of the members that has a high-cost health plan. At least that's our initial feeling on that. So at this point, it would come back to the consortium. There's been no formal decision on how that would be distributed. My guess is it would go directly back to the specific employer that that caused the fee to be charged in the first place.
Is there an analysis of the benefit, or is the Cadillac plan definition entirely based on the cost? Can it be that the benefits are so much better, the cost is worth it?
It is based on the benefit plan. So you load the benefits into the actual value calculator. It is also based on cost. Obviously, if it's returning a value that says this particular benefit plan is expected to pay about 90% of the benefits, it's looking at what's the deductible level, what's the copay level, what's the out-of-pocket maximum level, and it's comparing that to a database of medical costs to say, okay, how does that match up to the overall cost we expect the average person to pay in a given year?
So maybe my Cadillac plan is covering 94.56% of the patient cost.
The formal definition of a platinum plan is that it...
I'm looking at the Cadillac plan, Steve.
Oh, the Cadillac plan, yes. The Cadillac plan could definitely be in excess of a platinum plan, and most likely will be. My guess is that the platinum plan level will stay just below the Cadillac tax over time. But if you're exceeding that benefit level, then your costs are going to be a little bit higher in terms of premium, which means that you're more likely to hit that Cadillac tax. So that's true, yes.
Thanks.
Yep.
Where does Cadillac tax come now, a paycheck under consortium health insurance, or does it come out in health insurance only, it don't come out of our...
It wouldn't be billed back to individual people. It would be, no, it would be billed to the consortium, and then the consortium would have to charge it to the employer. Now, how the employer builds that into their costs, I don't know. That's a bridge we have not crossed. I have no idea how that would ultimately happen, if it would be built into premium and then it would be shared, or if it wouldn't be shared. I don't know the answer to that today.
Okay.
Yes?
Is there some kind of a COLA built into that $10,000 figure you showed us?
Yeah, the question is there a COLA built in, a cost of living increase? There is. However, it's an undefined inflationary escalator at this point. It just indicates that it would be increased by a medical care inflationary factor to be determined by the United States Department of Health and Human Services, but it's yet to be defined at this point. In terms of future expectations, just to kind of give you an idea of what we're looking at in terms of costs down the road, it's really not that different than what we've seen in the past. You know, obviously medical care inflation will impact us, advancements in medical technology, advancements in pharmaceuticals, federal and state mandated benefits. I will tell you that it's our opinion that this will be a little bit of a lesser impact down the road, because even when you look at, potential mandates that are coming through the pipeline today, it's far less than there have been in the past, partly because we're pretty much covering everything now. I mean, there's not that much left. I mean, you see things like for, hair pieces and other things. So they're grasping at straws now to try to find additional benefits to add through mandate. So that may be a little bit of a lesser impact. But certainly taxes and fees, and some of those hidden ones too. You know, there's taxes and fees that were built in the Affordable Care Act on the pharmaceutical industry and medical devices. There's all kinds of other things that are being contemplated. One of the things that we're concerned about is that now that we have to report the aggregate cost of health insurance on people's W-2s, that at some point down the road they may look at that as taxable income or a taxable benefit. That's a concern in terms of additional taxes and fees. So there are a lot of things down the horizon that we need to keep an eye on collectively to make sure that we can keep these costs in check and to make sure that we are not kind of priced out of the market, so to speak, in terms of health insurance. And with that, I will turn it over to Don for a quick summation and Q&A.
So any other questions? You've got the meat and potatoes of our event tonight. So hopefully this ties some things together for you and explains that this is really a big business and it's important work that the Consortium Board of Directors does. So please support them and also take this information back to your bargaining unit and to your board so they can appreciate what this consortium is up to. And we're always looking for support in many different ways. So just to have a couple of closing thoughts. We, the Greater Tompkins County Municipal Health Insurance Consortium, are unique in the health insurance marketplace. Cornell, Ithaca College, BOCES are all self-insured, but we stand alone as the only insurance company. Article 47 provides labor with opportunities not found in any other insurance model. Remember the three-legged stool that Beth's initial slide? As an insurance company and patients, we are two of the three legs. We have unique opportunities to manage our future. We have the responsibility to provide security for one another by keeping the efficient health consortium stable and financially strong. We have an obligation to one another to use health insurance wisely by making choices in both lifestyle, diet, and preventive care that keep us healthy. And when we are ill or injured, making informed choices of the best care available at the most reasonable price. Our insurance is our safety net. Let's work together to keep it strong. Thank you so much. So I'd like to ask you to applaud our presenters. Okay, this is what you've all been waiting for, and I thank you for sticking around. This is the raffle prizes, so I'm going to let the Beth and Ashley team handle this.
Okay, raffle number 1, and this will be for the chair.
Okay, last 4 digits, 0033. We have a lucky winner. There you go. Perfect. Okay, we have a few more. Here we go. Last 4 digits, 0004. Oh.
You have to be present to win.
All right, I'm going to call another one.
Going to go again.
Last 4 digits, 0027.
Oh, here you go.
Okay. Next prize is 0025.
Yoga mat. You're welcome.
Bread basket.
Bread basket. Goodies.
0028.
You get them so close to one another. Don't spend it all in one place.
We've got a picnic basket.
Picnic basket. One last one after this. 0014.
0014.
Going once. Going twice. Okay. Then we are drawing another one, 0002.
Then we've got a backpack.
All right. And then we have one last prize of an Excelis backpack, 0026.
Yeah.
Okay. There we go. We will try 0031.
It's a latecomer. All right.
There you go. Perfect.
There you go.
So thank you all so much. And there's food back there that Beth and Ashley don't want to take back, so fill your pockets up, and you can still talk with one another if you'd like, and thank you.